بسم الله بسم الله الرحمن الرحيم. الحمد لله رب العالمين والصلاة والسلام على سيد المرسلين. Good evening, ladies and gentlemen. It's my pleasure to welcome you in this scientific session. My name is Abdul Halim Kinsara. I'm a professor of cardiology in the Ministry of National Guard Health in Jeddah. I'd like really to thank Bristol Myers Squibb for this really arranging a very important topics that is become more recognized and in the matter of fact growing up because we start to have a treatment for it. Hypertrophic cardiomyopathy has been always a challenge in the diagnosis, a challenge in management, and a challenge in follow-up. Today, it's our honor to have Dr. Ismail Raslan. Ismail is an assistant professor of cardiology at King Fahad Cardiac Center at King Saud University Hospital. Dr. Ismail have a subspecialty in advanced heart failure, heart transplant, and mechanical support. He is also certified in cardio-oncology. So I think with his really expertise in this field, I'm sure he will enrich us by a lot of the scientific data that is we need to manage this difficult disease. So share with me in welcoming Dr. Ismail. Ismail, the floor is yours.
Thank you very much, Prof. Kinsara, for this kind introduction. It's my genuine delight to be with all of you today to talk about an important topic and also something that I'm very passionate about. Hypertrophic cardiomyopathy is a disease to stay, and the science and the evidence keeps on evolving. So I do thank the organizing committee for this invitation. These are my disclosures. And as was announced, this is the outline for our talk for today. And then at the very end, we will open the floor up for questions. It's always nice to start with a case. So I'll give you a case of a 43-year-old female who presents in the context of ventricular tachycardia, arrest while at the gym. She has been giving us history of NYHA class 2 symptoms for the last 6 months, which she attributes to her being out of shape. She also gives history of palpitations. She has a family history of a father who died suddenly at the age of 50, and also a brother who died despite knowing how to swim at a young age. She doesn't take any medication, she has no allergies, and her social history is otherwise unremarkable. As part of the workup, she gets an echo, and the echo, as you can see over here at the very top, shows that she has significant left ventricular hypertrophy, an LVOT gradient that is present at rest and at Valsalva, and evidence of diastolic dysfunction. So I want you right now in your mind, just think about what is your next step in the management? What are you supposed to be doing? And how are you going to proceed with this case? And we will circle back to this at the very end, inshallah. So when you're talking about cardiomyopathies, we need to really go back to what the European Society guidelines that was published in 2023 tells us. So it tells us that a cardiomyopathy is a myocardial disorder in which the heart muscle is structurally or functionally abnormal. The most important thing is in the absence of the common things that you rule out usually. So coronary artery disease, hypertension, valvular heart disease, and significant enough to cause myocardial abnormalities. So within the most recent guidelines, they put them into several large categories, and hypertrophic cardiomyopathy falls under one of these categories. And it is basically hypertrophy that is defined in the presence of increased LV wall thickness with or without RV hypertrophy or mass that is not solely explained by loading conditions. So your athletes, your hypertensive patients are not these types of patients. And it's a very big umbrella term that could actually include other types of diseases that morphologically presents with hypertrophy. Now, what is considered as quote unquote thick? So an LV wall thickness that is more than 15 millimeters in any one or more of the myocardial segments in any imaging modality. And in children, we use a Z score that is more than 2. As you can see in the very bottom picture, the difference between a normal heart and a thick heart with hypertrophic cardiomyopathy. This is also coupled with different types of changes, which we will go to shortly. I really like this slide because it provides us with a lot of information, because HCM at least has been with us for 150 years. And there is also evidence that tells you that it might have actually been there for further before that. And the other thing is it's definitely here to stay. And one of the things you know is as you go forward, the evidence keeps on changing. You see when Brownwell had his case theory, when we had our CAF finding in the 1990s, is when we identified causal genes. But when we really sat down as a scientific group and came up with a guideline, it was in 2003 with Meron from the US and our colleagues from Europe came down together and generated the first consensus document. Fast forward to 2011, is that's when they took part. So that's when the American guidelines went separately. 2014 is the European guidelines. And thereafter, the revised American guidelines in 2020, 2023, we've got the European Society Cardiomyopathy guidelines, and most recently in 2024, the updated American guidelines. There are several landmark trials, such as the Pioneer HF by Hinter, also the Explore HCM trial that also came out with Dr. Elivato. And then there is all what happened in 2023, and there is all what's going to happen in the near future. One of the things that we hear a lot is that HCM is rare. I tend to disagree with this statement, and a lot of people in the scientific committee agree that it is underdiagnosed, underrepresented. The fact that you did not look for it does not mean that it does not exist. So based on prevalence studies, the prevalence is somewhere between 1 to 500 or even 1 to 200. So in the States, there are about over 600 people that are still undiagnosed with HCM. Switching gears to the pathophysiology and the subtypes. Now, from a pathophysiological standpoint, I need you to focus on one important aspect, that you have to keep in mind that the LVH is not the phenotype of the disease. It's basically what the disease presents like. So presents phenotypically as if you have thickness of the vessel, but basically physiologically, it's hypercontractility. That is the pathophysiology of HCM. So the story really goes under the dynamic coupling system in the filamental system between the thin filaments and the thick filaments. It's a sarcomeric related story at the level of the sacromere. So this is what we mean by sarcomeric HCM. So in the thin filaments, you have your tropomyosin, and also you have your troponin that is activated and coupled with calcium that results in the shifting and hindering availability of the actin to attach to the myosin and create what we call bond myosin. And that's basically your contraction. And that is an ATP produced activity that continues to go on and on and on. What you have to keep in mind is that the myosin is present in 3 states. So we have the bound myosin, which is the cross-bridge force that necessitates ATP, the on myosin, which is the disordered relaxed myosin form, and the off myosin, which is what we call the super relaxed form. So if you were reading into this topic 8 years ago, off myosin would not have been actually there. So as we told you, things keeps on evolving and things keep on changing. So to depict this picture even further, you have to keep in mind that if you go to the gym, for example, to exercise, you hypertrophy your muscle. And if you think about this thin, thick filament interaction, the cross bridge that takes place, if we are to think about the extremes, so a naturally occurring strong state is basically your HCM. But a naturally occurring weak state is basically your dilated cardiomyopathies. Going back to the off myosin status, usually it's present in the off state. Think about it as a fold in upon itself, a sleep state, basically. that is not active and it's not ready to engage. So, for example, if you decide to go and run a marathon, you require more power and you require more training and you require more recruitments. So, you spend about 10 weeks getting ready for that marathon. And what that means is you're recruiting these off myosins to be rendered available for you. You can't simply jump from the couch to go to a marathon. So, in the contrary, when you're talking about HCM, they have these myocytes active and hindered and ready to work on a constant state. So that's what I wanted to point your attention to. So that was at the cellular level, at a histological level. If you look with me to A, so that is basically a normal histological slice. B and C are histological slices that show disorganized myocytes. And basically on D is where you appreciate fibrosis at the level of the heart muscle. When we talked about the pathophysiology, we talked about thickness, we talked about the cellular changes, but I want to also point your attention that there are also mitral valve dysfunction that also takes place. So the mitral valve could be morphologically abnormal, the leaflets can be elongated, you can have accessory muscles, the insertion can also be abnormal. Genetics is a very important aspect of HCM, and the two most common
Ismail,
variants
can you please repeat the last sentence because it was interrupted? Can you repeat it, the last sentence?
from the previous slide.
No, this is slide you also. Yeah, this one. Yeah.
Yeah, I was saying that the mitral valve morphology tends to change in HCM. So you can either have elongation or abnormal insertion or accessory pap muscles in these patients. The the genetics is also very important. As we said, the first genes that were identified was back in the 1990s, and the two most common variants are the myosin binding protein C3 and the myosin heavy chain, which is present about 50 and 30% of the time, respectively. We also know that patients who have pathogenic sarcomeric mutations are more likely to have adverse outcomes. And in this registry, times twofolds more than other members. When we're talking about the subtypes of HCM, it's important to group them into whether they are obstructive or non-obstructive. And obstructives are usually with an LVOT that is more than 30, and non-obstructive that are less than 30. When we're talking about obstructive HCM, the question is, why is it obstructing? And you have to keep in mind that this is a dynamic process. And that's why whenever you find a heart, you have to really, a thick heart, you have to really spend the time and interrogate, looking into whether there is a gradient, whether it's at rest or with provocation. And that is a class 1 indication. And the reason why you have that gradient, it could be because of narrowing at the level of the LVOT, anatomical changes, as we mentioned before, in the mitral valve, or SAM, or systolic anterior motion of the mitral valve. Another important subcategory is to also describe what kind of morphological changes you see. So the thickness is not necessarily all asymmetrical septal. So you can have sigmoidal, reverse curve, and apical, but the most common type is asymmetrical septal HCM. I really like this graph that was provided by Elijah Arrigo in the European journal, where it tells you the trajectory of your HCM patient. You would think that your trajectory is always linear, but not necessarily true. So if you have your patients with HCM, they can be in a non-hypertrophic state, and then they later on can go into a full obstructive, or what we call a classical phenotype. Based on that, they have several pathways that they can go into. They can remain stable over time, and we've seen some of those, and we have them in the clinic where, you know, they've been persistently stable, there is thickness, there is no gradient, and they've been doing fine. And the later stages is adverse remodeling, and then you go down to overt dysfunction. So these are the 4 stages that we talked about. So the non-hypertrophic stage, the classical stage, adverse remodeling, and ongoing overt dysfunction and fibrosis. When it comes to making a diagnosis, in my mind, the avenues where us the cardiologist, the internist, the general practitioners can get in contact with these patients are these 6 avenues. So it's they either present with exertional symptoms, abnormal physical examination with murmurs on maneuvers, for example, a family history of sudden cardiac death, or they tell you we have HCM in the family, LVH on echocardiography, or an abnormal ECG. Just a quick question, Dr. Kansara. Is the screen clear and in full mode?
Yes, it
And
is.
it seems a little fragmented from my end. Or
No,
it's
it's from here, it's full screen and it's perfect.
fantastic. And then when it comes to the test to confirm the diagnosis, there are numerous amount of tests that you can consider, and I'll get to that shortly. At the end of the day, you're an investigator trying to collect all the necessary information to help you reach to the next best step. So have it being a physical examination that's suggestive of a murmur on augmentation, whether you do an ECG and the ECG is suggestive of obstructive HCM with signs of LVH, if you have evidence of biatrial enlargement, S waves in V2, V3, or tall R waves, or if you have an apical type where you have deep T wave inversions. But in the end of the day, it really all falls down, at least in the beginning of the conversation, to a good old-fashioned echo that gives me the information that I need and a serious, genuine attempt of interrogation of the LVOT gradient. The next phase is basically deciding what are the burdens and complications you're expecting. So what are the boxes in my mind that I have to keep in mind while I'm encountering my patient with HCM? So the first thing is basically debilitating chronic symptoms, decreased functional capacity over time, atrial fibrillation and thromboembolism, sudden death and risk stratification, and heart failure. But the question that you get asked all the time from these patients with HCM, if you were to think about these boxes, is really not these boxes. And it really takes you at a surprise sometimes to realize that the most common question they have is this: living with the disease. So a lot of the time when you sit down and you ask them, they tell you that my biggest concern is what's going to happen to me in 2 years and 3 years and 5 years? What's going to happen to my children? Are all my children affected? Are they all going to go through this pathway that I have? How am I going to screen them? Are they going to die? Etc. And I encourage you, and I encourage myself, of course, to really focus on these important aspects in these discussions with your patients as well. We also know that your HCM patients have higher likelihood of all-cause mortality, more than 3 to 4 times their counterparts from the general population. Also, they have higher risks of heart failure and atrial fibrillation in comparison to the normal population. This is a very good algorithm, to help you navigate the diagnosis of your patient. So when somebody comes in where you're suspecting HCM, start off with a good old personal history and physical examination addressing your symptoms. Thereafter, you have to take at least 3 to 4 pedigree history from your patients. And a simple, do you have a history of coronary artery disease or heart disease is not sufficient in your patients. You really have to sit down and draw the pedigree and share that with your patient. Later on, you would proceed with an ECG and echo plus minus cardiac MRI, depending on if you consider there are also other etiologies that could be suggestive of hypertrophic cardiomyopathy. Thereafter, you need to decide whether your patient has the obstructive type or non-obstructive type. So you start off by looking into whether there is resting obstruction or provocable obstruction, or they have a non-obstructive type. Also, if it is available for you, genetic testing could also be helpful, not only for your patient, but also deciding on how you're going to screen the family moving forward. So I give you this example of a pedigree of a family where the father has hypertrophic cardiomyopathy, with an MYBC3 mutation. The partner does not, and you can see that they have apical aneurysm at the age of 58. He has 4 children. The first child is basically phenotypically positive and genetically positive. The second one as well. The third one carries the mutation, but phenotypically, they did not exhibit the disease. So this is what we call incomplete penetrance in these patients. And as opposed to the last one, who does not have the mutation, who also does not manifest the disease. Switching gears right now to the evidence for cardiac myosin inhibitors. To start off, I'll tell you what mavacamten is. So mavacamten is a small molecule that is selective allocytic, that causes selective allocytic inhibition of the cardiac myosin. To further expand on what we talked about in the pathophysiology area before, mavacamten is basically a targeted inhibitor of the cardiac myosin that reduces the number of myosin-actin cross bridges and decreases contractility in an effort to improve compliance, improve energetics, and also attenuate the hypercontractility. In a more simplified fashion, it's pretty much like you're transforming a heart that is a Bugatti into a diesel-run truck to some extent. Moving on to talk about mavacamten. Mavacamten has been here for a while, and it's gone through a lot since 2016, all the way now almost 10 years later, with pivotal trials that took place, starting off with the phase 2 trial, the Pioneer HCM, and then the Explore HCM, and the Valor. I think I went back by mistake. Excuse me. Okay, so starting off with the Explore HCM study. So it was a phase 3 multicentric randomized double-blinded placebo-controlled parallel trial in 13 centers, and they looked into the effect of mavacamten 30-week course in comparison to placebo on clinical response that comprised of several things that we're going to go into shortly. There was a primary endpoint and secondary endpoints. So the study design was patients that are NYHA class 2 to 3 that are symptomatic with a peak LVO2 gradient that is more than 50 at rest, or that gets provoked at screening with Valsalva. Also, they were randomized, as we mentioned, to 1-to-1, starting off with a dose of 2.5 that was later up-titrated in a 2-step fashion. So you get enrolled to the study, and then you get followed over time for a total of 30 weeks with opportunities where you have echo-guided up-titration. So the primary composite endpoint was, the first was a 1.5 millimeter per kg per minute increase in your PVO2 with a more than 1 NYHA class improvement. The composite 2 was a more than 3 increase with no worsening of your NYHA class, and there were other secondary endpoints listed below, which we will go through shortly. I point your attention to the demographics table, and as you can appreciate, that they were very much balanced. They were also symptomatic as well to begin with. Now, when it comes to the echo parameters, they are in keeping with the inclusion criteria for the trial. When it comes to the primary composite outpoint, at 30 weeks, you can appreciate that nearly 37% of the patients on mavacamten achieved the primary endpoint, which representing the doubling of the response in comparison to the placebo group. We also appreciate that in the composite, the first composite and on the second, and also 20% actually achieve both of these composites. When you look at the post-exercise LVOT peak gradient, you can appreciate that there is a significant, statistically significant difference of minus 47% in this group in the mavacamten in comparison to 10 in the placebo group. When it comes to changes in peak VO2 as well, it was statistically significant. NYHA class more than one improvement has also been achieved more statistically significant and dramatically in the mavacamten group. Also, by the end of the 30 weeks, there was about 50% of these patients who became NYHA class 1. And you can appreciate that the NYHA class 2 to 3 are getting shrinking and smaller over time in comparison to the placebo group. Other secondary endpoints was the Kansas City questionnaire and the HCMCQ that also showed a statistical significance. When it comes to the safety endpoints, they were very merely balanced. There was no significant side effects between both. 3 patients discontinued because of adverse effect, 2 on mavacamten and 1 on placebo, but there was no patient withdrawal due to reduced ejection fraction, which was less than 50 persistently as part of their study protocol. The question that everybody has in mind, including myself when the study first came out, is, you're giving them a myosin inhibitor. Shouldn't that drop your ejection fraction? And what is the rate of drop in ejection fraction over time in these patients? And the short answer is not very much. So it was about 4% in the mavacamten group in comparison to 0.1% in the placebo group. And for those who drop their ejection fraction less than 50, the protocol is to hold and then re-challenge again. Switching gears to the Valor HCM trial, which was a randomized, double-blinded, placebo-controlled, multi-center phase 3 study in the United States that evaluated the effect of mavacamten on reducing the number of septal reduction therapy in symptomatic obstructive HCMs who are eligible for septal reduction therapy based on the 2011-2014 guidelines. So the objective was to determine whether mavacamten to the maximally tolerated dose can basically allow those patients not to meet guideline criteria for septal reduction therapy at 16 weeks. And this is the study design. So what you can appreciate is they start off with randomization to mavacamten versus placebo. And the mavacamten groups goes for a full 32 weeks with possibility of essentially up titrating the dose as they go forward. The placebo group goes on for 16 weeks and thereafter goes into mavacamten, and then they revisit their outcomes as they go forward. The primary outpoints were a composite first, that was the decision to proceed with septal reduction therapy at 16 weeks. And the second one was the consideration for guideline eligibility for septal reduction therapy. And there were other secondary endpoints that were similar to the first trial, and we'll go to them as well as we go forward. Key inclusion criteria is you really had to be symptomatic. Think about the patient who was eligible for septal reduction therapy, very symptomatic. They went through the algorithm, beta blockers, etc. And basically that is the group that you included. You had to have an LVOT gradient and you had to have an EF that is more than 60%. And of course, they excluded the patients who are already been treated with septal reduction therapy for these patients. Demographics is very well balanced for these patients, and you can tell that the majority is class 3 or higher for these patients. And these are the recommended interventions that they were referred for. When it comes to the echo parameters, they are also balanced. Medical therapy in this study, they were allowed to use disopyramide, and you can appreciate that they all have elevated BMPs and troponins going into the study. Going on to the results section, so after 16 weeks of treatment, there were 18% in the patients in the mavacamten group versus 43, 77 patients in the placebo group who were elected to undergo septal reduction therapy procedures or continued to meet the guideline criteria for septal reduction therapy. And that is a dramatic drop that took place. Also looking into the post-exercise LVOT gradient in a similar fashion to what we saw in the Explore-HF. We do appreciate there is a significant reduction that takes place. Also, when it comes to the NYHA class improvement at week 16, they continue to improve in comparison to the placebo group, which has minimal improvement. When it comes to the non-serious treatment events, it was overall fairly balanced in this group. There was 2 episodes of atrial fibrillation, non-sustained ventricular tachycardia occurred in the placebo group as well. And then there was your broad, non-specific adverse effects that was reported. Switching gears to the most recently published trial in the European Heart Journal, the Sequoia HCM study looked into aficamten in these patients who have an LVOT gradient, who are symptomatic, and they looked into a 28-week period with 3 episodes of up titration in these patients. And what this trial chose as its primary endpoint is the change in peak VO2, which also demonstrated an improvement. They also showed in a similar fashion that your resting LVOT gradient improved. Also, your NYHA class and your Kansas City questionnaire improved as well. The other question that comes to mind is, what about long-term data? Right now, the longest long-term data we have is from the mavacamten group, and you can tell from the Explore-HCM and from the extended Valor-HCM that these effects are sustained over time in these patients. Switching gears to what the guidelines tell us. So starting off with the European guidelines, the shift took place from 2014 to the 2023 guidelines. And in your obstructive patients who have a LVOT gradient than more than 50 with symptoms, then you should start them off on a beta blocker. Followed by that, you would, if your patient is intolerant to beta blockers or still symptomatic, you can consider switching to verapamil or diltiazem. If your patient is still symptomatic, then at that point, you can consider disopyramide as an add-on to your patients. Now, if you focus with me on the stepwise approach that we talked about now, you would realize that most of the targets that we talked about are away from what we've talked about in the pathophysiology. So it's away from the sacrometic process that we talked about until right now, where we have therapies that really target the pathophysiology that takes place. And that's why mavacamten is listed in the European guidelines as a class 2A for these patients who remain symptomatic despite your therapies. The question that comes to mind, you do have randomized data. So why isn't this a class 1 indication? And most likely is because they're looking into head-to-head comparisons with other agents, such as beta blocker, and there is a trial that is in the cooking at the time being. And then, of course, if your patient remains symptomatic, then considerations can be for septal reduction therapy. And the guidelines tells you cardiac myosin ATPase inhibitors in titrated to the maximum dose can be considered in addition to beta blockers, or if it's not possible, verapamil diltiazem to improve symptoms in adult patients with gradients, 2A. What about the American guidelines? The American guidelines, up until 2020, had a change in the guidelines that we're going to go through shortly. So patients with HCM, you basically decide early on whether they are obstructive versus non-obstructive. And if they are obstructive, then you really need to think carefully about the use of vasodilators and high-dose diuretics in these patients. You start them off with beta blockers or verapamil diltiazem, depending on how your patient responds best. But this is really where things are different. In comparison to the European, you find that they are all on the same level. So myosin inhibitors, disopyramide, and septal reduction therapies. And this is different. The other thing that you need to keep in mind is they lump them together under myosin inhibitors, as opposed to the European guidelines where they explicitly say mavacamten 2A in these patients. And what's also interesting is disopyramide, for example, is given a class 1 where it has no way near the evidence that is available for mavacamten right now. You would also expect that you would proceed in a stepwise fashion, i.e., you would try medical therapy before you go down to surgical therapy. But realistically speaking, in the clinics, and these are the discussions we have with our patients, is we sit them down and we tell them, hey, these are the available options right now, and these are our recommendations, and we have a shared decision-making process. So I assume that's part of why they are all on the same line, and thereafter you can consider septal reduction therapy. Going back to the story that we started with in the beginning of the presentation today, so much has happened in the last 150 years, but so much is happening in the last 10 to 6 years alone, and the future is still very bright. So there are more trials that are going into the agents. We have right now gene-specific therapies that are being produced in the pipeline. So stay tuned because the future is still evolving. Taking you back to our previous case presentation. So what was the treatment course for this patient? So she was found to have a positive gene mutation, MYBC3. She had an ICD that was implanted for secondary prevention. She was started on maximally tolerated doses of beta blockers. Symptoms persisted. Disopyramide was added, remained symptomatic, and then she was initiated on mavacamten. And as you can appreciate that in this scenario, there has been a significant change in the gradients over time with mavacamten, where your gradient went down from 136 to 6, and also the diastology has also improved. So going on to the conclusion and take-home messages, I want to remind you that the management of HCM is evolving. HCM is not a rare disease. It's a disease that is underdiagnosed, and we need to be more vigilant about HCM. Cardiac myosin inhibitors are truly, truly a game changer in the management of HCM. You need to have a personalized treatment plan, and it is the key dealing with your patients. And as we did mention before, the future is evolving, and hopefully we can improve our outcomes and improve our diagnostic accuracy. Thank you very much.
Allah يديك العافية جزاك الله خير Ismail. It really was a very excellent presentation. I think the number of the attendee proves that we are mashallah tabarakallah 100 attendee. So thank you very much. I think you drive us very well with your Lamborghini car from the beginning till the end. And open the floor for the question. Please write down your question in the Q&A icons, which is at the bottom of the screen, next to the green bottom share. Let us see what's the question here. The first question I have, it is beneficial to symptomatic patient after myomectomy?
Well, I think the short answer is we really don't know. And we know that patients who had myomectomy after HCM has likelihood of reoccurrence in the future. So I would assume that likely if you redeveloped your phenotype of HCM, then you might actually respond to the medication. But at the time being, I don't have the data that supports this notion right now.
Thank you. The second question, patient with obstructive HOCM with a history of drop in his ejection fraction, but later on it was recovered and now it's 55%. Could we challenge him with mavacamten?
I think that's not unreasonable, but when we are prescribing mavacamten, I think we need to follow what the guidelines says and what the trial has practiced in these patients. So the inclusion criteria was to be more than 60 in your ejection fraction, but also you need to follow them up to make sure that their ejection fraction doesn't drop before 50. And if their ejection fraction does drop, what was done is there was an interruption in therapy that was reobserved again. And if they recover their ejection fraction, they can continue on with their therapy.
How frequent you recommend the Zyco follow-up in such patient when you up titrating the dose?
I think it depends on two things. It depends on what agent you're using and what protocol you're using. So if you're using mavacamten, then I think that you should follow what they did. So they had three areas to stop at their uh, at at their treatment. Or in these patients, I think another good strategy is symptom-driven adjustments. Because in the end of the day, you have to keep in mind when you're starting mavacamten, there are two important aspects. What is the starting dose and how much I can increase the dose over time and what is their response.
So our up titration will be symptom dependent.
And basically following the protocol, which is 2, 4, and 8 weeks, for example.
Okay. Could we use mavacamten with mid-cavity HCM?
I think that really depends on, I think the question is non-obstructive HCM. If the question is non-obstructive HCM, at least right now, what the guidelines tell us and what the evidence tells us is we are good to use it in obstructive cases. There are trials that are in the pipeline soon to be published that is going to answer that questions. And there are basically non-randomized cases and case series that looked into that. But the short answer is for the time being, we should stick with the obstructive HCM.
Is a limit age?
I think for the time being, there has been older populations in these patients. As long as you fit the inclusion criteria, I'm not aware of a age limitation for these patients. But of course, pediatrics, though, are not included in these studies. They have to be more than 18 years of age. There is a study that's going to look into pediatrics, and pregnant females is not studied as well.
Thank you. Is there any other contraindication to mavacamten apart from dropping the ejection fraction?
I would counsel you to the general run-of-the-mill symptoms. So if you have like severe reactions, if you have anaphylaxis, etc. But I'm not aware that that ever happened. But I think the other contraindications to me would be pregnancy and basically depending on your CYP metabolizers, because if you have inefficiency in your CYP metabolization, you're more likely to develop more side effects in these patients. And that's why before we start the treatment, we actually send for CYP analysis to help us decide what is the starting dose and what's the up titration dose.
And this test, is it done in the kingdom or outside the kingdom?
It's done actually through the company. They've been very generous in helping us with that. So what they do is when we identify a patient, then basically they're willing to send the lab, get us the result, and help us basically get them started on the treatment.
Oh, that's great. What will be the best management plan with a patient with HOCM family history?
Well, I think what really depends on these patients is you need to decide whether you have the capacity to do genetic testing or not. And if genetic testing is available for these patients, then it makes things a little bit easier for you. So I think the first thing to do is you need to screen everyone. And that's what the guidelines tells you. So whenever you capture somebody with HCM, you need to send for an echo and an ECG for everybody in the family. That's your screening test. And then you can consider repeating every 3 to 5 years. Now, on the other hand, if you have somebody like we presented in the beginning of the slide, where you have somebody who's genotypically positive, and then you test the family and you have somebody who's genotypically negative, then at that point, the likelihood of developing HCM is low to non-existent at that point. So I would start with the screening, and it's basically a class 2B to continue screening these patients.
Yeah, that's great. Thank you. After CYP test become rapid, how fast we could go for up titration in this medication?
So if it was ultra rapid or if it was a poor metabolizer?
It was become rapid, actually, is the question.
Okay, so if your patient was ultra rapid metabolizer, you start off with 5 milligrams as opposed to 2.5. And then basically you look again at 4 weeks, 8 weeks, and 12 weeks. But if your patient is a poor metabolizer, then at that point you have to start at the lower targets, 2.5, and then you would look again 4, 8, and 12. Of course, you could look sooner depending on your symptoms.
Okay, that's great. One of the challenges actually in this patient is is how long you need to follow them up. Suppose you give them the medication
Mhm.
and then if the gene test came back negative, will you continue following them up lifelong?
So if we had the luxury of doing gene testing, and I know, for example, let's say the father is phenotypically and genotypically positive, and I did the progeny testing and it's negative, I would screen them the first time. You can look again in 3 to 5 years, but basically they're very unlikely to develop any symptoms, especially if they're negative. If they don't carry the gene, which was genotypically and phenotypically positive, then I don't see an added benefit of continued screening in these patients.
Okay. Allah يديك العافية. Maybe Captain, like the studies we saw looking to the symptoms and gradient, what about the change in the anatomy itself, changing in the muscle thickness, changing in the mitral regurgitation? Would that will be affected as well or not?
Well, what is evident is basically you're decreasing your workload on the heart, you're decreasing the contractility. So, as evident by the LVOT gradient falling down, then the thickness also falls down. The mitral regurgitation, I think it depends if it's related to loading conditions, but as we alluded to before, a lot of these patients have structural changes within the mitral valve itself, and that is not likely to improve. And I think that's one of the things that you have to keep in mind when you're talking to your patient, because if you have a surgical mitral valve disease, then maybe in these patients you should really have a discussion about septal reduction surgical therapy with mitral valve, depending on your individualized care for these patients.
Great. Do we have a series of HOCM or we have any HOCM registry in the country or not yet?
The short answer is not yet. So the approval, alhamdulillah, was recent for mavacamten. It's now Saudi FDA approved, and collectively, I know that there is a lot of interest right now from a lot of sites. So inshallah, we're going to be working together to start a registry. I think our population is going to be very unique in comparison to different populations. For all we know, we might not necessarily carry the same gene mutations that other members in the world carry. So I'm very interested to know, and I'm very interested to collaborate. And I want to extend this invitation to everybody on the call. I did put my email and my social contact. So at any point, if you have a patient with HCM, if you want to collaborate, just push me an email. I'll be more than happy to work together.
Allah يديك العافية. If the patient develops side effect from myosin inhibitor, how long should we stop the drug? And if we are to restart the medication, should we start it at a lower dose?
So it's somewhere between the 2 to the 4 weeks is when you would stop your medication, and then you would challenge again. Ideally, you would challenge at a lower dose from what you reached. So you would just step down by one dose as opposed to going down to the very beginning.
I really like to thank the audience because they are really giving us a very nice questions, and they illustrated something that is was maybe was not stressed. I think they really, I'd like to thank them again for staying with us, putting these nice questions. I'd like also to thank Dr. Ismail Raslan for really driving us through these difficult topics. MashaAllah, tabarakallah, you did a great. I'd like to thank the company, Bristol Myers Squibb, for getting us in this scientific committee, and also for Kunuz Retaj. And inshallah, we'll see you in another scientific event بإذن الله. الله يديكم العافية جميعا ونشوفكم دائما على خير. وشكرا على مشاركتكم معنا إلى الآن.
يعطيكم العافية جميعا، شكرا جزيلا.
شكرا حبيبي، نشوفك على خير يا رب، الله يوفقك
شكرا.
وينفعك. شكرا، مع السلامة.